Good morning. I hope all of my friends are doing well. Today I would like to discuss about ulcer. Before going to ulcer, I would like to just differentiate between the definition of wound and ulcer. A wound is a breach in the continuity of skin or mucous membrane, whereas an ulcer may be defined as a persistent breach in the continuity of skin, mucous membrane associated with cell death. Now, as surgical trainees, you will be asked to present cases both in long case and short case, a patient presenting with ulcer. So how we try to present ulcer and what are their types, how we can examine them and how we will treat them. First of all, how we classify ulcer. Clinically, we can classify ulcer in three groups. One is the spreading ulcer, one is the healing ulcer, and lastly the callus. And if we try to classify it pathologically, we can divide it into three groups, that is specific ulcers, malignant ulcers, and non-specific ulcer. Among the specific ulcers, we have the tuberculosis, syphilis, actinomycosis, and melanus. Among the malignant ulcer, we have the carcinomatous, rodent, and melanotic. Among the non-specific ulcers, we have a lot. We have traumatic ulcer, arterial ulcer, venous ulcer, trophic ulcer, infective ulcer, tropical ulcer, cryopathic ulcer, Martorell's ulcer, Bézine's ulcer, diabetic ulcer, cortisol ulcer, and miscellaneous. Now, by examining or depending on the depth of the ulcer or the tissues involved, there is a classification which is known as the Wagner's classification. Here we have divided the ulcer into 5 grades. Grade 0 is the pre-ulcerative or healed. Grade 1 is a superficial ulcer. Grade 2 is deeper to subcutaneous. Grade 3 is abscess formation. Grade 4 is gangrene of the part of the tissue. And grade 5 is the gangrene of the entire limb. Now, what are the parts of an ulcer? The ulcer has 4 parts. They are margin, edge, floor, and base. Among the edge, there are different types of edges, and if you examine them properly, they will give you a specific indication what kind of ulcer you are dealing with. We have the sloping edge, which is common in venous ulcer. We have punched out edge, which is common in neuropathic ulcer. We have undermined edge, which is present in decubitus ulcer. We have rolling edge, which is present in basal cell carcinoma. And we have everted edge, which is present in squamous cell carcinoma. Now the margin. The margins can be of 3 different types. It can be regular margin, it can be an irregular one, or rounded or oval one. And the floor. Floor, we have to see 2 different things. One is the granulation and another is the discharge. Among the granulation tissue, in a healing ulcer we get a red granulation tissue which will be pale and smooth, or sometimes the floor might be a wash leather pattern, or we might find a pink, punctate, pulseful, painless, pin-headed floor. Sometimes we find an exuberant floor. Among the discharge, we might find a serous discharge, purulent discharge, seropurulent discharge, bloody discharge, serosanguinous discharge, and sulfur discharge. Now base. Base is that part of the ulcer on which the ulcer rests. Base is normally we palpate the base and it remains indurated in case of malignancy. It is a very important finding in case of malignant ulcer. Now the traumatic ulcer. Anywhere in the body we might find this kind of ulcer, especially in the limbs, shin, malleoli, joints. It can be chronic due to staphylococcus infection, or like plaster sores, dental sores, footballer's ulcer, skin burns, and caustic ulcer. Among the arterial ulcer, we get an inadequate skin circulation, the limbs repeated pressure or trauma. Causes are arteriosclerosis, normally present in the anterior and lateral legs and dorsum and heels. Then we have a very common disease which is due to an arterial ulcer, that is the Burgess disease. There will be painful claudication and punched out ulcer. Now the venous ulcer is the commonest on the leg, especially on the medial lower third. There will be of the leg, and there will be a pigmentation, and the causes are normally, the commonest cause is the varicose vein due to perforator incompetence or stasis. And the another thing that might lead to venous ulcer is a deep venous thrombosis. These are due to valveless recanalization. Now the trophic ulcer. It is a neurologic deficit, impairment of blood supply and nutrition. The common sites of trophic ulcers are sacrum, heel, buttock and occiput. Sometimes due to bed sores and perforating ulcers are present. The causes are diabetic neuropathy, paraplegia, leprosy, spinal injury and peripheral injury. Now what is a tropical ulcer? Tropical ulcers are commonly present or found in kinds of tropical countries. Causes are basically not known. These are also known as the callus ulcer. Now, the commonest ulcer that you find in surgical ward is a diabetic ulcer. It is caused due to diabetic neuropathy, the atherosclerosis, and another thing is known as the glucose-laden tissue infective. The tuberculosis ulcer is very common in our part of South Asia. Causes bursting of caseous lymph node, slightly painful, commonly present in the neck, axilla and groin. It is undermined, thin reddish blue edge, serosanguinous discharge and induration. And side by side we will find enlarged local or regional lymph nodes. Now the syphilitic ulcer, it is normally caused by the Treponema pallidum. There will be hard chancres in external genitalia. It will be painless, indurated base, somewhat button-like. Commonly other places which is present is the nipple, lip, tongue and anal canal. Secondarily, mucus patches are common in this kind of cases. Now the malignant ulcer. The commonest malignant ulcer that we get are the Marjolin's ulcer, that is due to from SCC, and malignant ulcers are commonly present in the lips, cheeks, penis, vulva, mouth and esophagus. Normally patients are above 40 years and the commonest cause are squamous cell carcinoma, basal cell carcinoma and malignant melanoma. There are some other ulcers that we get. These are known as soft chancre. It is normally painful, presence in external genitalias with bubo. We might get also Melanese ulcer, that is post-operative perforated viscous empyema thoracis and normally infected with streptococcus and staphylococcus. Then we have martorell ulcer, which is present in hypertensive old age patient due to post cough. Now, how do we take the history of an ulcer case? First, we have to know the mode of onset, then the duration, whether pain is present or not, whether discharge is present or not, whether any previous treatment is taken or not, which is not healing the ulcer. Now, how do we examine the ulcer? In case of examination, in inspection, we have to see the size and shape of the ulcer, number of the ulcer, position of the ulcer, age, margin and floor, whether there is any discharge from the ulcer and also the surrounding area. And in palpation, we have to see whether tenderness is present or not, age and margin, base, depth, bleeding and the surrounding skin. Side by side, few other very important things we need to examine in case of examining an ulcer. Those are local and regional lymph nodes, peripheral pulsation, nerves, joints for mobility, and systemic examination for other comorbid conditions. What are the investigations that we can prescribe? Some routine examinations like complete blood count, random blood sugar can be done. Side by side, some specific investigations like a study of the discharge. We can take biopsy from the edge, an X-ray of that part, FNAC of the lymph node, chest X-ray, and color Doppler in case of venous and arterial ulcers. Now, how do we treat a case of an ulcer? The simple way, we have to find the cause and treat the cause. Correction of deficiencies, blood transfusion if needed, pain management, and regarding the management of the wound, we have to do debridement, cleaning, dressing, proper antibiotics, and in certain big ulcers, we have to think of suturing, grafts, and flaps. I hope these are the commonest thing that we need to know as surgical trainees while we are discussing a case of ulcer. Thank you.